again. Welcome to the Module 7 synopsis, Suicide, Mood Disorders, and Grief. Go ahead and check out the module objectives. Take a look at each one, make sure you feel like you've met them, and if you haven't, go back through the lessons and see if there's anything in there that can help you make the connections. What surprised you when learning about any of these module objectives? Many different types of patients will express suicidal ideation, which are thoughts of suicide. It's our job as nurses to screen patients at admission and throughout their stay to make sure that we identify risk factors, assess severity, and keep the patient safe and move them towards well-being. We need to perform an environmental risk assessment, which entails looking over the environment. Even if we know a room to be a safe room, we still need to make sure that there's nothing in there that could be a danger to the patient. Make sure we're screening for suicidal ideation with a validated tool. An example of a screening tool is called the Patient Safety Screener. You can find more information on that, the Suicide Prevention Resource Center, linked in your online text. Then we have to assess suicide risk. An evidence-based suicide risk assessment should be completed on any patients who have screened positive for suicidal ideation. An example of this is the Columbia Suicide Severity Rating Scale, or the C-SSRS. Hopefully you followed the link and you've taken a look at that scale. We have to make sure that we have a safety plan in place. It's a prioritized written list of coping strategies and sources of support that clients can use before, during, or after a suicidal crisis. Always document. A suicide screening and risk assessment should be documented, and it needs to be communicated with the treatment team along with a plan. Make sure you're following written policies and procedures very strictly. When we're addressing the care of individuals who are identified as a risk for suicide, this is of the utmost importance to make sure we keep them safe. Also, we need to provide information for follow-up care upon discharge. That's written information and reading for follow-up care for clients identified at risk for suicide and their families and loved ones as appropriate. Studies show that a patient's risk for suicide is high after discharge from psychiatric inpatient or emergency settings, so developing that safety plan is incredibly important. You also have to make sure that they know the crisis numbers, local and national, and make sure that they have a support network in place at discharge. What feelings do you think you will experience the first time you have a patient that screens positive for suicide risk? There are a lot of different possible causes of depression, including faulty mood regulation by the brain, genetic vulnerability, stressful life events, medications, and medical problems. When it comes to the brain, certain areas help regulate mood, including the hippocampus, amygdala, and hypothalamus. The hippocampus is part of the limbic system. This is a part of your brain that registers fear when you're confronted by a frightening situation. The hippocampus is a little smaller in depressed people. Research suggests that ongoing exposure to the stress hormone impairs the growth of the nerve cells in this part of the brain. The amygdala is also part of the limbic system. It's a group of structures deep in the brain that are associated with emotions like anger, pleasure, sorrow, fear, and sexual arousal. The hypothalamus is involved in the stress response. The stress response starts with a signal from the hypothalamus. The hypothalamus, pituitary gland, and adrenal glands form the hypothalamic pituitary adrenal axis, and that governs a multitude of hormonal activities. Neurotransmitters. There are many types that play a role in depression. Acetylcholine enhances memory, involved in learning and recall. Serotonin helps regulate sleep, appetite, and mood, and inhibits pain. Norepinephrine constricts blood vessels, raising blood pressure, and it may trigger an anxiety response that's involved in some types of depression. Dopamine is essential to movement. It influences motivation and plays a role in how a person perceives reality. Glutamate. It's a small molecule, but it's believed to act as an excitatory neurotransmitter and to play a role in bipolar disorder and schizophrenia. GABA, this amino acid that researchers believe acts as an inhibitory neurotransmitter. It's thought to help subdue anxiety. Humans have almost 22,000 genes in their DNA with 46 chromosomes inside the nucleus of each cell. It is thought that there is a genetic component to depression. Throughout life, different genes turn on and off and make the right proteins at the right time. However, genes can alter the biology in a way that results in a person's mood becoming unstable. In a person who's genetically vulnerable to depression, any stress, like a missed deadline at work or a medical illness, can then push the system off balance. It's a well-known fact that depressive disorders and bipolar disorders run in families. Mood is affected by dozens of genes, and as our genes differ, so does depression. Genetics just provides one perspective on how resilient an individual is in the face of difficult life events. Temperament is determined by a person's genetic inheritance and the experiences they have in life. Stressful events are also a cause of depression. At some point, nearly everyone encounters stressful life events, like the death of a loved one, the loss of a job, or the diagnosis of a severe illness, even the end of a significant relationship. A lot of people have had traumatic childhoods, and it continues to affect their coping and functioning. Stress triggers a chain of chemical reactions and responses. If the stress is short lived, the body usually returns to normal. But when stress is chronic or the system gets stuck in overdrive, changes in the body and brain can be long-lasting. Every real or perceived threat to one's body triggers a cascade of stress hormones that produce physiological changes called the stress response. Normally, a feedback loop allows the body to turn off the fight or flight defenses. In some cases, though, the floodgates open and they never close properly. Cortisol levels rise and then stay too high. And these high cortisol levels can turn into high blood pressure, immune suppression, asthma, and depression. There are certain medical problems that are linked from anywhere from 10 to 15% of all depression. So, one is hypothyroidism. The body produces too little thyroid hormone and leads to exhaustion and depression. Some other diagnoses associated with depression are degenerative neurological condition, CVAs, which are strokes, nutritional deficiencies, endocrine disorders, immune system diseases like lupus, some viruses, cancer, and erectile dysfunction in men. So, different types of depression. There are depressive episodes in each type, and that's when a person experiences depressed mood, feeling sad, irritable, empty, or a loss of pleasure, interest in activities. The different types of depression: there's major depressive disorder, which is 5 or more symptoms are present during the same 2-week period and represent a change from previous functioning. There's persistent depressive disorder, where somebody is depressed for most of the day for at least 2 years. Premenstrual dysphoric disorder: in the majority of menstrual cycles, at least 5 symptoms are present in the week before the onset of menses, and they start to improve after the onset of menses. There's substance and medication-induced depression, which is a persistent disturbance in mood that develops during or soon after substance intoxication or during withdrawal from a substance. Depressive disorder due to other medical conditions, or a period of persistent depression that is the direct consequence of another medical condition. There's also seasonal affective disorder. It's a type of major depressive disorder that affects about 5% of adults in the U.S., and these people experience mood changes and symptoms similar to depression, that they occur during the fall and winter months when there's less sunlight. Postpartum and perinatal depression. Peripartum depression. So postpartum depression has feelings of extreme sadness and anxiety and exhaustion and make it difficult for new mothers to complete daily care activities for themselves. It needs to be treated, because if it's left untreated, it's not only a problem for the mom, but also a problem for baby. So the type of major depressive disorder that happens during pregnancy is perinatal depression, and that affects 3 to 6% of women. As future nurses, it's really important that you guys all know that we need to look out for our pregnant and newly delivered moms. If these symptoms of the pregnancy-related depression are not treated, postpartum psychosis can happen. They'll have delusions, mania, lose touch with reality, and they can possibly hurt themselves, their family, friends, or their children. Individuals can experience depressive episodes classified as mixed, meaning they alternate with the depressive state through periods of manic symptoms like euphoria, irritability, increased talkativeness, increased self-esteem, decreased need for sleep, distractibility, and impulsive and reckless behavior. Either from this module or from personal experience, and obviously you don't have to say which one, but which depressive disorder are you the most familiar with? We have another great screenshot from your book. However, I really like this one as well as the other one that I used. I think it's a great representation of the continuum of mood disorders with depressive disorder at one end and psychosis, and mania and psychosis on the other end. There's a lot of different things that fall in between, so make sure that you understand what those are and why they fall where they fall. Also, please make sure that you have watched the video Youth Voices Kylie Versosa on Depression. On which part of the mood disorder spectrum do you feel that the clients would be the most challenging to treat? It's difficult to cope with the loss of a loved one, the loss of a job, or the end of a relationship. It's normal to be sad and for grief to develop in response. Sadness is not the same thing as depression. The grieving process is natural and unique to each individual, and depression and grief do share some of the same features, but there are differences. With grief, painful feelings come on in waves and they're mixed with positive memories. In major depression, the mood or lack of interest and pleasure are consistently decreased. In grief, self-esteem is maintained. In major depression, feelings of worthlessness and self-loathing are very common. In grief, thoughts of death may surface when thinking or fantasizing about joining the deceased loved one. In contrast with major depression, the thoughts are focused on ending one's life due to feeling worthless or undeserving of living. Grief and depression can coexist. When grief and depression occur together, the grief is more severe and lasts longer than grief without depression. Nurses must be able to distinguish between the symptoms of grief and depression and assist people in getting the help, support, and treatment that they need. Depression is one of the most treatable mental disorders. Between 80 and 90% of people with depression eventually respond well to treatment. Almost all patients gain some relief from their symptoms. We talked in depth about antidepressant medications during psychopharmacology. Antidepressants are used to regulate and increase neurotransmitters in the brain to improve mood. There are several classes of antidepressants with different mechanisms of action and different adverse side effects. Please make sure you take a good look at the table in subchapter 7.4 that lists the medications, the class, the mechanism of action, and the common side effects. A black box warning is a significant warning from the Food and Drug Administration that alerts the public and healthcare providers to serious side effects such as injury or death. There are black box warnings in place for all classes of antidepressants used with children, adolescents, and young adults due to the higher risk of suicide. All clients receiving antidepressants should be monitored for signs of worsening depression or changing behavior, especially when the medication is started or a dosage is changed. There's adverse side effects with antidepressants. Keep an eye out for these in patients that you have that are prescribed. Thoughts about suicide, attempts of suicide, worsening depression, anxiety, agitation or restlessness, panic attacks, trouble sleeping, irritability, aggression, anger, or violence, dangerous impulses, increased activity and talking, and other unusual changes to behavior or mood. Serotonin syndrome is a dangerous side effect, and it is from high doses of antidepressant or a combination of medications that affect serotonin, like antidepressants and triptans. Triptans are usually used to treat migraines. This is a medical emergency. It's extremely variable, ranging from mild symptoms to life-threatening symptoms. It takes about 24 hours from the increased dosage or combination of medications, and it can be fatal. Symptoms: mental status change, agitation, restlessness, or delirium, autonomic hyperactivity, which is tachycardia, hypertension, hyperthermia, diaphoresis, shivering, vomiting, or diarrhea, or neuromuscular hyperactivity, which is tremor, muscle hypertonia or rigidity, myoclonus, hyperreflexia, or clonus, which includes rapid horizontal eye movements. There's a mnemonic used to remember the symptoms of serotonin syndrome. It's called SHIVERS. S is for shivering, H is for hyperreflexia, I is for increased temperature, V is for vital signs, there's abnormalities, E is for encephalopathy, which is mental status changes, R is for restlessness, and S is for sweating. People can get slowly worse, and they can become severely ill if they're not quickly treated. Treatment of serotonin syndrome: stopping all serotonergic medications, providing supportive care to normalize vital signs, sedating with benzodiazepines, and for persistent symptoms, the doctor may have you administer cyproheptadine, and that blocks serotonin production. Serotonin syndrome in its most severe form can resemble neuroleptic malignant syndrome. Another side effect is hypertensive crisis. This can happen with clients taking MAOIs who also take medications containing pseudoephedrine or eat foods containing tyramine. It's very important to provide patient education when a patient is on or being prescribed an antidepressant. They need to be instructed that it'll take 4 to 6 weeks for antidepressants to be fully effective, and they should never suddenly stop taking antidepressants or they'll experience withdrawals. When it's time to stop the medication, the provider will slowly and safely decrease the dose. If they stop taking their medications before the provider advises, depression may return. They might feel better with the first antidepressant they try, or they might need to try several different classes. Psychotherapy is another treatment that's used for depression. It can be used alone in mild depression or in combination with antidepressant when there is moderate to severe depression. And we went over the specifics of psychotherapy in prior modules, so I'll just touch on them. There's cognitive behavioral therapy, there is dialectal behavior therapy, and there's also the holistic therapies, the humanistic therapies, and the integrative therapies. Electroconvulsive therapy is a medical treatment reserved for patients with severe major depression who have not responded to medications, psychotherapy, or other treatments. It involves a brief electrical stimulation of the brain while the patient is under anesthesia. The client typically receives ECT 2 or 3 times a week for a total of 6 to 12 weeks. Nursing considerations for ECT: pre-procedural education, securement of informed consent, pre-procedure preparation, screening tools used pre- and post-ECT to evaluate side effects including memory loss, medication administration, and post-ECT care such as monitoring vital signs for changes in airway, breathing, circulation, and implementing fall risk due to the patient just having come out of anesthesia. Transcranial magnetic stimulation is newer. This is a non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain to improve symptoms of depression. TMS is typically used when other depression treatments haven't been effective. It uses a magnet to activate the brain. Unlike ECT, where the electrical stimulation is more generalized, TMS can be targeted. Sessions last 30 to 60 minutes, and patients don't require anesthesia. In addition to the treatments mentioned, nurses can also teach clients many coping strategies to reduce symptoms of depression. For example, regular exercise helps create positive feelings and improves mood. Getting enough quality sleep on a regular basis, eating healthy diet, avoiding alcohol, as it's also a depressant, can also reduce symptoms of depression. Give an example of a misconception about any of the treatments for depression. It is not part of your required reading, but if you want to take a look at applying the nursing process in the context of depressive disorders, check out subchapter 7.5 in your main textbook. That's it for the Module 7 synopsis. Way to go, everybody. Let's keep learning.